Our next speaker is Dr. Michael Burke. He received his undergraduate degree from the University of California, Irvine Medical School at Ross University School of Medicine. He did his pediatric residency at Medical College of Virginia, Pediatric Hematology Oncology Fellowship at Northwestern University Children's Memorial Hospital here in Chicago, and currently is the assistant professor at the University of Minnesota and Platt's Children's Hospital in Minneapolis. And his talk today is going to be on the oncolytic virus trial. Dr. Michael Burke.
Okay, well, thanks a lot to Pat and to Donna for inviting me here to speak to you. I think this is a great opportunity and an exciting, I think, trial that you'll find interesting. Talk about a virus that can target a cancer and kill it. So here's some points I'm going to discuss today. Really is just define oncolytic viruses, maybe a new term for many of you. What exactly are they and what do they do? How do they relate to neuroblastoma? That's why we're all here. And then specifically talk about the Seneca Valley virus. This is the virus that is in the current Children's Oncology Group trial, ADVL-0911. So what is it, where did it come from? Some information, data on the adult study, which was quite encouraging and led to the current pediatric trial. So just in very basics, an oncolytic virus is any virus that targets a cancer and kills it. Most of the time it's through invading or attaching to the virus or to the cancer cell, getting inside, replicating, and then destroying it as it leaves. This is known as direct destruction to the cell. But sometimes the virus can actually be a carrier of a protein that may target the cell and kill it. But very targeted therapy by nature. These are not new. It's not a new entity. It's actually been quite old therapy. Over 100 years ago, it was noted some patients who got infections and had cancer had some responses. And some of them, that had immunizations or curative disease. Maybe this was some of the first oncolytic therapies back then. And it may turn on an immune response against the tumor. So sometimes, some cancers actually occur in patients after some infectious period or some vaccine, and maybe a question of if it was immune-mediated or immune-assisted. The same token, some cancers can be targeted or attacked from the immune system, and sometimes infections trigger this immune system or vaccinations. And past 20 years, more so now, but technology really exists now to manipulate viruses to make them more targeted toward cancers and to try to get the best out of the virus and not have it cause infection, and to grow these viruses and to make them available for therapy. So this is how, a little cartoon schema of how this works. That you have a virus that gets into a tumor cell and it replicates, and then as it leaves the cell, it destroys the cell through what's called cell lysis. The virus spreads and attacks more cells, more tumor cells. But where in the healthy cell, it does not have the ability to replicate and dies within the cell, or sometimes won't even enter the healthy cell. So that would be ideal. So this is basic virology 101. I'm your instructor. This is a picture of the virus, a viron. They do require living cells to grow and replicate. And they like to destroy the cells and spread, so they're very much a parasite. And this is a common schema. This is not specific to any one virus per se, but the virus will then come into a cell, go into the nucleus, and the viral DNA or RNA will then go into the sort of the genome of the cell and use the cell structure to function, to replicate, make proteins, and to make new viruses, and then leave to go to new cells. So take advantage of the host and move on. So human viruses were used for oncolytic back in the 60s, and these are the most common one. Herpes simplex virus, adenovirus, polio, and Coxsackie, the common ones that were used. But the problem was we didn't have or the investigators back then didn't have a good idea of how to harness these. And so when they put in these live viruses, they caused havoc in the patient like these illnesses would. So they had led to uncontrolled infections, and oftentimes they changed the immune system of the patient so they no longer responded to the virus and could deactivate the viruses. So there's a lot of consequences, toxicities from that. But they did see some responses to tumors, but they weren't complete, they weren't durable. But I think it did give some ideas that this may be a potential option, just not in this fashion. So that led to viral engineering. Let's take a virus that may target a cancer, kill a cancer, but change the elements of it such that it doesn't cause disease in the patient. And try to modify them so that they maybe only target cancer cells. That would be ideal, and to leave the rest of the patient alone. So the first sort of, this is China's FDA, but the first virus that was really manufactured for clinical use was an adenovirus, which can be quite an aggressive virus. This was done in 2005 for head and neck cancers. And they tended actually not to invade and replicate and infect cells like some of the oncolytic therapies I'll be talking about. But they did see with chemotherapy and the viral infusions that they had more response than chemotherapy alone. And again, this is the idea of the virus actually homing to antigens on the cell, coming in, sometimes integrated into the DNA, but oftentimes not, and making new virons and then releasing into the blood and continuing. As far as neuroblastoma, this is a number of in vitro, or we call in the petri dish type of work that was done both with herpes simplex and adenoviruses, both cell work in mouse models. So neuroblastoma cells from patients that were then sort of immortalized and used for studies, or mouses or mice that you inject with tumors and then treat with these. They injected these viruses into the tumors of the mice or systemically through tail veins, and they saw a pretty remarkable shrinkage of the tumors in mice. In fact, once the infusion had stopped, comparing to mice that didn't get the virus, there's a significant lag in the regrowth of the tumor in those that had received viral therapy. And here's a schematic to that. So this is the size of tumor on this, what we call the y-axis, and then days after infection. These are actually days that the virus, the herpes simplex oncolytic virus, was infused. This is just salt water, so you want to just see what the effect of the injection into the tumor. Had no effect. The tumor grows rapidly. These are two different viruses that were then injected. And you can see it has nice tumor control while the virus is injected into the tumor, and then when they stop, the regrowth is quite a bit different than the control. And so then you take these mice with the tumors and do cross-section of the tumors, and those that got the saline, you don't see any virus particles, but in the tumors you see multiple areas of the dark brown as the viruses that picked up on the stain, which is sort of proof of principle of the virus replicating within the tumor in these. So oncolytic viruses in the clinical trials, I know what I'm going to be talking about today is the first ever in kids, but this is not a new concept nor first clinical trial. A number of viruses, mainly herpes and adenoviruses, but Rio, Newcastle, some measles viruses, and a lot of carcinomas. So there's prostate, squamous cell, bladder, ovarian tumors, some liver and brain tumors that have been. Some of these are ongoing or proposed. But Seneca Valley virus, NTX-010, this is what it looks like in a cartoon fashion. But this is really interesting and fortuitous how this came about. This is a non-engineered virus, so this is not a manipulated virus. This is a live virus as it comes, and it belongs to picornavirus family. So picornaviruses are your common cold virus, the rhinovirus. They're also enteroviruses, diarrhea viruses. Those are the same family. They're very small, and this Seneca Valley is actually targets just neuroendocrine cancers. These are cancers that express proteins or have proteins of neural origin. Neuroblastoma is one of those. I'll mention some others as we go forward. And this is an RNA virus. It's not a DNA virus. Again, those are the common relatives. But this was discovered almost by accident. So if you work with cells in culture, the viability of keeping the cells alive is very important for your studies. And anytime cells just start to die off, you get worried about contamination. And so there's common bacteria or fungus, viruses that may actually get into the petri dishes and kill the cells. And that's essentially how this was identified, that in porcine trypsin, trypsin's an enzyme that breaks down proteins, and fetal bovine serum, this is a supplement you add to media to keep cells healthy and happy and feed them, that this virus was in these, in the trypsin and the fetal bovine serum that was being added to the cells, and it was identified in that fashion. So in a few slides, I'll show a panel of cancer cells that were screened with this virus. That's typically how you identify a target population if you have a new agent. And so this, this virus at some point, it's referred to as a drug. So in any new drug trial or therapeutic trial, you may have a screening panel of cells to see which is the type of patients or disease you may want to target. And it was really patients with these neuroendocrine-producing tumors. And so what they did is they, in early studies, gave this intravenously in quite high amounts of virus particles into mice, pigs, really chimpanzees, and humans that had different neuroendocrine tumors, small cell lung carcinoma, particularly carcinoid tumors. And no matter what dose they were giving, they did not see any really dose-limiting toxicity. And they didn't see any disease, so any result of the viral infection. So they didn't come down with diarrhea or colds or anything else like that. And also, it seemed to be not transmittable, which is important. If you're giving somebody a virus, are they contagious or not? So this is studies where they injected the virus into one mouse, and they housed a mouse that had the virus with one that didn't for a period of days. And then they checked the mouse that did not receive it for antibodies against it or any exposure to it, and there was no evidence. Nothing was found. As well as laboratory personnel that were working with the virus, testing them for antibodies exposure, and none of them mounted any antibody response to it or had any evidence of it. And also patient caregivers. So in the adult trial, some of the nurses or doctors that were around the patients that received the virus, some of those a few number were screened, and none of them had any evidence of viral transmission. So that's great. What am I describing? A non-pathogenic, meaning a virus that doesn't cause any disease, and it's safe across all these different species. The viral replication has been found in all species, and really no dose-limiting toxicity. That's great. So what they have seen is transient drop in white blood cell count, kind of viral syndrome, fever, chills, fatigue that you may have with an illness, viral illness. And a lot of these doses, these are fairly high doses for this virus that I'll get to, but really it's a safety of intravenous infusion that's been shown in a lot of preclinical, so that's non-patient trials. So again, large small cell lung carcinoma is a neuroendocrine tumor. This is one of the more tested cancers in the preclinical pathway for this agent. These are mice that were basically injected with small cell lung cancers in the hip there and allowed the tumors to grow. They injected then these tumors directly with either the saline, which is called the vehicle, or with the Seneca Valley virus. This is 1 × 10⁻13 viral particles per kilogram for the mouse, directly into the tumor, and you can see it was a one-time injection, and over a period of time, the tumor volume went down to essentially nothing for 50 days after the injection, and mice were sacrificed. So here's a panel. These are all different cell lines of cancers. Here's some normal non-cancer cells. And it showed the amount of virus killing the cells. So the higher bar, the more killing. And these are these are the ones really that are highlighted are ones that are neuroendocrine type of tumors, lung carcinoma. But in the pediatric, there's a number of retinoblastoma, neuroblastoma, and Ewing's, and medulloblastoma, but that had very high killing. And none of the normal cells had any effect from this virus. Okay, so some of the desirable attributes of an oncolytic virus. So it's a coronavirus. It's a small virion. It penetrates the tumor mass easily, and it does not integrate into the host, which is very, very important, that this is not something that gets into the person and carries with them. It has rapid replication and cell lysis as it leaves. It has very broad species tropism, so we're able to study, meaning both pigs, mice, chimps, and humans. It's been able to get in and not have any pathologic infection in any of the preclinical models. Low incidence of pre-existing immunity. So in the adult trial, they had 30 patients when they reported they were enrolled, and they checked for antibody titer to this virus before you get it to make sure that whether they've been exposed to it or not. And just one person of those 30 actually had antibodies to it, and he worked on a farm, so that was possibly that this virus was in his pigs or not. But so it's non-engineered. It's genetically stable. It's highly selective to neuroendocrine tumor cells and very potent killing efficacy with benign safety profile. And it's easy to manufacture, which is great. And so this is a schema. We infuse it, 1 hour infusion. It goes to tumor cells, replicates, destroys, leaves. Body makes antibodies and clears the virus. So the adult phase 1 study came to completion. Again, they had 30 patients that were dosed in the phase 1 study. Most of them had carcinoid tumors, quite uncommon in kids. And then the rest had small cell lung cancer, various neuroectodermal tumors. And the patients that were enrolled were all actively progressing refractory resistant disease. And the RECIST criteria is a criteria of measuring response. And so they all had really relapsed refractory disease and heavily pre-treated prior to the study. Their dosing range was 10 to the 7th to 10 to the 11th viral particles per kilogram. And throughout that, there was no dose-limiting toxicity, meaning the toxicity was so bad that we had to either stop the study or prolong the study, or drug-related severe adverse events, SAEs. There were, so the drug is the virus. There were drug or virus-related adverse events, but they are typically all mild flu-like symptoms for 1 to 2 days and resolve. And this is a single-agent viral infusion. There was no other chemotherapy given. But there was no real relationship between the viral load and side effects. I mean, some of the patients had a very high viral load, didn't have any side effects. Some that had less viral load had side effects, and vice versa. So it wasn't a clear correlation, meaning the more you get, the more toxicity you have. And they did see some response. That the small cell lung carcinoma patients had 3 times improvement in overall survival, which was compared to basically patients in the same scenario of 3rd and 5th line treatments. Carcinoid patients probably had the most radiographic response. They have a 70% response, partial response by PET, near partial response by CT, or stable disease by CT or PET. There were 10 patients that were evaluable, so they had some, spectrum of responses, some minor CT responses, some stable disease, a decrease in chromogranin A. So what they did in the adult studies, in a number of them, they actually had tissue prior to viral infusion, and then they actually had a biopsy or tumor resection, lymph node resection after virus, so they could then see if virus replication was taking place inside the tumor. Chromogranin, that's a pathologic stain or so, a histopathological stain. That's a neuroendocrine stain. Some tumors express chromogranin A, and they saw decreased expression of this in some of the tumors, which they thought was, maybe indicative of response. And there were some patients that had no response and also that progressed. Here's a picture of a carcinoid. One patient had a carcinoid tumor. This is a CT scan 1 week prior to infusion, and had 2 lesions here, and 6 weeks after, essentially, complete resolution of those. Several patients experienced prolonged stable disease, and some patients had reported symptoms of improvement, but not necessarily radiographic, with decreased pain. So all these patients had their blood and their stool, and this was at so the higher infusion amount, 10 to the 11th. And the viral copies essentially were cleared in all patients by 2 weeks, and in the stool essentially by essentially all patients by a month. And by 2 weeks, all patients had antibodies against the virus. So some of the conclusions: it was detected in all patients in the serum and stool after the dosing. The viral kinetics based on these assays showed that it was likely that these were replicating within the patients. And all patients cleared the virus within 2 to 4 weeks from both the stool and serum. All patients developed antibodies against the virus, which then cleared the virus. And once patients had detectable antibody, there was no further virus detected in the patient blood or serum, so that was correlated nicely. This was a patient actually on autopsy with small cell lung carcinoma that had liver disease. This is the same liver. This was unaffected and showing no virus there, whereas in some of the areas of liver metastases, these are all brown. These are all the virus that stained, which was interesting because in this patient they had already antibodies produced and no serum or blood evidence or stool evidence of virus, but still had virus within the tumor at time of death. Okay, so how does this impact us here? So this is a bit of an overview. This is an ongoing trial that I can speak about, but this is ADVL0911, the Seneca Valley virus in kids. This is the first ever oncolytic viral trial in children in the world. And here is the list of diagnoses. These are all considered neuroendocrine producing tumors, or tumors that have certain protein markers that we believe this virus would target. That's based on preclinical data in some of the animals, as well as cell lines. Patients must be 3 years or older, less than 21. Typically, this age was come about because since you're releasing the virus in the stool, we want patients that are essentially toilet trained or able to not be incontinent and have more infected time periods with incontinence. It's given as a 1-hour infusion. It's a single dose. Currently, this study in the phase 1 is a single dose. And we follow these patients for a minimum of 28 days or until they've cleared the virus. In the adult studies, all of them cleared it prior to this time, but whichever is longer, and the dose will not be repeated. It's a one-time. The design of the study is to start at 1 × 10 to the 9th, and we're going to escalate up to 12 and not go any higher than that. The adults essentially went a little bit higher, but this is where we're going to stop for the time being. When patients get infused, we check blood and stool twice a week, essentially every 3 to 4 days for the first 2 weeks, and then at least once a week until you have clearance of both blood and stool. And the expected toxicities are really what we've seen in the adults in the general experience of other oncolytic viruses. So just general oncolytic viral toxicities tend to be flu-like symptoms, sometimes hypotension with infusion. That's a general oncolytic virus toxicity. But otherwise, headache, nausea, vomiting, fatigue is what would be expected. So to date, 3 patients have been enrolled and completed, actually, the first month, all at 1 × 10 to the 9th. There's 2 that the first 2 actually had neuroblastoma, and the third with carcinoid tumor, and the study is ongoing. So some questions, actually, these are via Pat, so these are, I thank you for these questions. These are great. So maybe some that you may have, and I'll take others when I finish this. But when should an oncolytic virus be used, in bulk disease or minimal disease? So the interesting thing about at least Seneca Valley virus, it is a replicating virus. So this is a virus that, although you may give a low dose, you anticipate a much greater viral burden to occur in the patient. Once it gets into its target tissue, which would be the neuroblastoma, it replicates and multiplies such that you have a much higher disease load. So with that concept, maybe it would be fine with bulk disease. But I think what happens, and what you would suspect, is the body is recognizing the virus as a foreign pathogen and develops antibodies against it, even in your children that are very immunocompromised and have received a lot of chemotherapy, they still have the ability to make antibodies to infections. And so if you make an antibody to the virus and you clear the virus, then even though you've multiplied it, is that enough to work in bulk disease? So this answer is not known. I would suspect, unless you can blunt the immune system, that probably minimal disease is the best place for this virus currently. But that's a concept that is actually moving forward for this oncolytic virus and others, is the idea of giving multiple doses of blunting the immune system with some immunotherapy or chemotherapy that is more immunosuppressive, such that the host does not build antibodies to the virus, and you can give multiple doses and maybe use in bulk disease. So is oncolytic virus the same as vaccine therapy and immunotherapy? And I'm confused, what is all this? So oncolytic virus, again, is a virus that in itself is the agent, is the drug. It directly targets the cancer, gets inside, most of the time replicates, and then destroys, as opposed to carrying some other adjunct to the tumor to cause the killing. So that's different than vaccine therapy. A vaccine therapy would be you're exposing a patient to a protein that is similar to one or the same as one that's on a tumor. So the body recognizes that protein in the vaccine is foreign, and the immune system then targets that protein, which happens to then be on the cancer, and attacks and kills. Immunotherapy, some of these can be kind of all put into the same hat, but a classic immunotherapy is antibody therapy, so antibody directed toward a cancer, or maybe a reagent that is not a protein of the cancer, but just stimulates the immune system to then target cancers. So these are all a little bit different. Are oncolytic viruses readily available from the manufacturer? And actually, no. So these are under pretty strict lock and key. You cannot get an oncolytic virus for kids outside of this pediatric clinical trial. And there's nothing off the shelf or compassionate use at this point in time. So the only cartoon I could find that had a virus was this one. I thought it was pretty clever, but antivirus program. So that would be your antibodies against the virus. But I can be happy to take questions.
Hi, this was really, really interesting, and my question is, does it target disease, neuroblastoma, in bone marrow or in soft tissue, or both?
Both. And in fact, I thought you were going to maybe ask a question if it penetrates into the CNS. Again, there are a lot of unknowns when we're talking about children with neuroblastoma in this virus, okay, because there's only 2 in the world that have been treated. So if we look at what we can learn from adults or mouse or animal models that have had this virus injected in, as far as where has the virus gone. So the virus does penetrate into the CNS. I mean, I don't know to a degree that would be therapeutic to patients that had disease. But in animal models where the brain or spinal cord was then sectioned and looked for the virus, they did find virus. The virus tends to go to all tissues, but is rapidly cleared without really causing any sort of destruction in cells that are not neuroendocrine producing. So if you, at least in animals, when they injected the virus and within a couple days they sacrificed and they cut up all the different tissues, they found viral particles, much more so, or much higher degree in areas of tumors. But in the normal tissues they identified it. But then when they checked later, maybe a week or 2 later, it was gone from all those tissues. But it has been shown in animals to penetrate into the spinal cord and the brain. Patients with brain tumors were excluded for this trial, as well as patients that may have very large lung tumors. And one of the things that I saw in the adult trial, and actually it's not uncommon to any oncolytic virus, is you get a local tumor effect. As you can imagine, as the virus is replicating and destroying, there's a lot of inflammation, and the size of the tumors grow. And so actually, if you were to get imaging studies too soon after the virus is infused, you may see larger size of the tumor before it's actually destroyed and gets smaller. But before we gave viruses that may penetrate into the head and cause increasing size in a very confined space, we want to have a better understanding about how this virus works and if we're seeing any local effect in kids. But it does get into bone marrow, soft tissue, everywhere.
Thank you, Dr. Burke. I was curious, the slide you showed of the liver from the autopsy of the adult that showed that the virus was still present in the tumor. It makes me wonder if the virus is there, even if they progress. Is there a follow-on treatment that would not be a good idea? Say they do this trial and then move on to something else, say it's stable or you know, hopefully not progressive, but is there a treatment that would interfere with that action if it's ongoing? Is there any idea?
I don't believe that's known. I mean, I don't think so. Patients are, you know, strongly encouraged not to go on to another trial until they've, you know, cleared virus on this. You know, so we have a minimum of, you know, 28 days or viral clearance that we follow these patients. The way the virus works, it's not depending on the immune system of the host. So if you were to get any therapy that would interfere with the body's immune system, that would not impact. You know, this virus is replicating and destroys the cell that it's inside just by the nature of its replication and release from the cell. So it does not require any, you know, number of lymphocytes in a patient or any white count or any, you know, normal antibody function of a patient. So I can't imagine that there, really off the top of my head, of any therapy that would interfere with these patients. But it is interesting to think that even when the patient has cleared the virus, that it may still be in the tumor. Now, we're not requiring any resections of disease after infusion. You know, that could be too much to require for, you know, for a child, and it's not something that we would typically do. To know if the virus, in fact, in kids and these tumors is still present for what period of time, and that's just extrapolating data from what we saw in the adults.
Thank you. It's very good.
Okay, one more question.
Yes, we've discussed late-term effects with every other trial that has synthetic drugs and that kind of thing. So I kind of wanted to address that. You had one of your slides that had where you were testing your normal cells. I'm assuming those are differentiated cells that
Yes.
you were testing as a
Yes.
negative control. With cancer cells being more of your immature, non-differentiated phenotype, what kind of late-term effects, no offense to, I know all the boys that are affected by neuroblastoma, but if you were to have a little girl that was tested this way, my understanding were that viruses did not clear your body completely, they kind of lie latent. Would there be a chance that there would be some sort of problem when that little girl grew up and tried to start a family, and now you're seeing this virus infecting very early on embryonic cells trying to develop a baby?
Okay, good question. So I think there's actually 2 points within that question. The one is that, you know, so this is not coronaviruses in general are not viruses that get into the genome and become latent. So there's a number of viruses that do. You know, so varicella is a virus that you get infected and you have it, you know, for life. It's dormant. It can come back as zoster, things like that. The coronaviruses do not integrate into the normal cell's DNA, so they don't become latent and don't get passed on. So that's one. But these cells do target sort of very immature neural cells, and in mice, sort of embryonic mice, embryonic testes and some fetal tissues, the virus, you know, did integrate in. I mean, did get into those cells, and that's part of the, you know, the reason it's attracted to these early types of cancer tissues, retinoblastoma, neuroblastoma, these, you know, sort of blastoma, very immature tissues. But there is no evidence that this virus is carried on past its time of infectivity, which is roughly about 2 weeks prior to antibody formation and clearance of the virus from tissues outside of tumor tissues where it appears to stay in there longer. But once it leaves the tumor tissue, it's then essentially destroyed by the immune system. So that's one of the advantages of having a virus that does not integrate into the genome. Those are viruses you would have to alter, that you would have to manipulate, so they're not it's not a live virus, but it's part of a virus. It's a manipulated virus such that it wouldn't do that. Some of the DNA viruses have the potential of actually integrating into the cell, and it would have those problems that you raise or concerns that you raise. Yeah.
Okay. Thank you very much, Dr. Burke. Appreciate it. We do have to finish. If you could talk with Dr. Burke afterwards, because we have to be out of here by 5 o'clock.
It's just a quick question. Is
Okay.
it for frontline and relapse therapy?
Say that again?
Is it for frontline and relapse therapy?
This is for relapse refractory only.